Our next section is headache, and we're going to go through a type of each one and make each one unique and distinct for you. Types of headache are tension headache, migraine headache, cluster headaches, giant cell or temporal arteritis, and pseudotumor cerebri. Tension headache is common, the most common form of headache, which is a constant pressure. It's usually bilateral, doesn't have to be. Lasts for several hours. That's how you distinguish it from a cluster headache, which is multiple, shorter headaches. On physical examination, there is absolutely nothing. Now, by itself, that doesn't help you because there's nothing on physical examination for the vast majority of people with a migraine headache. But tension headache never has an abnormality on physical findings. There are no diagnostic tests abnormal. Again, that's not too useful either by itself because migraine headache has no laboratory tests abnormal, and cluster headache has no laboratory tests that are abnormal, and all of the management of a tension headache is basically to say, hey, it's not cluster, not migraine, not temporal arteritis, it's a process of exclusion. Let's use some nonsteroidals and other analgesics. The single most characteristic finding of a migraine is the complaint of visual disturbance. Doc, I'm having photophobia. I'm having photopsia. I'm having flashers and floaters and floating black dots in front of my eyes. I'm having electrical storms in my eyes. It's presenting to an ophthalmologist. It looks like there is short circuits and bright lights. That's an amazing thing. And visual disturbance, a vascular headache. Nobody understands why it's all visual, but it just is. Could be at the first branch of the carotids of the ophthalmic, but bottom line is we don't know. We just know it's a symptom complex. We know it's related to or associated with foods and menstruation. We know it's precipitated by emotions. We know that although there are very rare cases that have a complicated migraine, the term complicated means that there's actual neurological abnormalities. It means the vasospasm becomes so severe it starts to look like a stroke, man. Aphasia, numbness, dysarthria, focal weakness from a headache. Now, fortunately, this is in the vast minority. How are we going to answer the most likely diagnosis? Headache, visual problems, often related to food during a period. I ate chocolate during my period. I had cheese balls. I had chocolate-covered cheese balls. I'm having chocolate-covered cheese balls with red wine. And of course, the most dangerous, having chocolate-covered cheese balls with red wine during your period. There are no diagnostic tests that are specific. All of them are normal. Scan the head the first time. The first time, you don't know what's there. My goodness, could be a subarachnoid hemorrhage. If I saw a bad headache and photophobia, I'd be thinking of a subarachnoid hemorrhage. And you should, too. By definition, the sudden onset of severe headache with photophobia is not a migraine until you've excluded a subarachnoid hemorrhage. Then, by process of elimination, it would be a migraine. Because there's no diagnostic test to prove the migraine. There are diagnostic tests to disprove brain tumors and subarachnoids. They present you a patient with migraine. Say, what's the best initial therapy? That's actually easy. Abortive therapy is with triptans, sumatriptan, zolmitriptan, or ergotamine. The contraindications are also very straightforward. Very severe hypertension, coronary disease. If a migraine is a vascular headache, vasospasm followed by vasodilation, then triptans, which are vasoconstricting agents, ergotamine, which is a vasoconstricting agent, should reverse it. Reconstrict your brain. A person goes on nitroglycerin. What is the most common adverse effect of nitroglycerin? It's a headache. Why? Because nitroglycerin is a vasodilator. So vasodilators cause headache. Vasoconstrictors like triptans and ergotamine get rid of the headache. And the single most frequently asked question on step 2 is, what is the best initial abortive therapy? Make sure you don't mix up abortive therapy with prophylactic therapy. Prophylactic therapy is propranolol. If you have 3 migraines or more a month, if you're basically having 1 migraine a week, you should get prophylaxed with propranolol. Don't mix up prophylactic propranolol. Prophylactic calcium channel blockers, prophylactic SSRIs, prophylactic tricyclic antidepressants, prophylactic occasionally botulinum toxin injections into the scalp. Don't mix up those preventive therapies with abortive. This is the most frequently asked step 2 question for migraine. Well, there's no diagnostic test, so they can't ask you that. There's no unique physical findings, they can't ask you that. So what would you ask you? That you know how to abort the migraine with an injection, oral, or inhaled nasal triptans, and to prophylax it when it happens more than 3 times a month. Cluster headache refers to a symptom complex. Since it's nothing to be found on a test, it has to be a specific intensity, a definition, a frequency, a duration. Yes, that's it. A cluster headache is like the unstable angina of your head. It's not that there's something special on your head that you find. Although the physical exam will find that's 10 times more often in men than in women. And you can have a red tearing eye, and the tearing goes into your puncta and down into your nose. It leads people to misunderstand, thinking that this is a sinus problem. Because aren't you stuffy? Don't you have a stuffy nose? It leads people to believe it's a sinus problem when there's a stuffy nose. And occasionally a Horner's syndrome. But the most important thing for cluster headaches is that they describe to you a man who's got multiple short, sharp, high intensity, ice pick stuck in my head, ice pick in my eye, literally feeling like you've been stabbed in the head types of headaches. They last for a few minutes and then they get better. The diagnostic test, the first time that you get the person, you're going to scan them because you can't tell whether or not there's a brain tumor or hemorrhage, but you don't need to do subsequent imaging every time they come in. You do it when they first present to exclude hemorrhage and tumor. Men, short, sharp, repetitive, and red tearing eye. The treatment for abortive therapy is largely the same as migraine with triptans and ergotamine. Now, there is one unique thing, which is that there is an equally effective therapy to triptans, which is 100% oxy. It's equally effective, it's not better, and it's certainly much harder to get, much harder to obtain. They will not ask you to choose between these. They won't, because they're both effective. Triptans, ergotamine, and 100% oxygen. But which one is easier to get? Triptans. Now, I have something new for you here. That is preventive therapy, prophylactic therapy, verapamil, calcium blockers. We didn't say that before. We didn't used to say that somebody can get prevented and prevent them from having cluster headaches. We used to say, well, it comes, it goes, nobody knows. But now, a person has multiple frequent cluster headaches. Use that calcium blocker to prevent it from happening. Just remember, preventive therapy takes a couple of weeks often to have effect. That's why we didn't used to do it before, because the cluster was going away. Now, when it's bad, we use it. It prevents the next cluster. Only if verapamil does not work will we use lithium or steroids. Steroids can be effective. As a matter of fact, I put someone on just today because they weren't getting better with their other therapies to prevent it. Giant cell arteritis is the only form of headache that has a truly unique physical finding presentation, has a unique presentation with visual disturbance and jaw claudication. Now, by the time you get to visual disturbance, it is very, very dangerous, and the answer is always next best step is steroids, not to wait for the biopsy. Jaw claudication is also characteristic, meaning I'm chew, and the muscle hurts and the side of my head hurts. You get muscle pain and fatigue and weakness, because after all, this is a variation of vasculitis, and that vasculitis presents with tenderness in the temporal area with the visual loss. Because of vasculitis, the best initial test is a sedimentation rate or C-reactive protein. They will never ask you to choose between them. The sedimentation rate is done more routinely. And the most accurate test, of course, is a biopsy, and we give steroids. And, of course, the same question over and over again, which is don't wait for the results of the biopsy. Give the steroids first.
In evaluating headache, look for the associated symptoms, such as a band-like pressure around the head. It lasts for a few hours as a normal physical exam. It means you have a tension headache, and all you have to use is some non-steroidals and acetaminophen. Now, if you see an aura described in the case, photophobia, if it's related to foods or emotions, if it's related to menstruation, catamenial headache means a headache related just to the period. Look for people eating chocolate or cheese, red wine. Now, very rarely a migraine headache will be associated with a focal neurologic deficit if the vasospasm of the cerebral vessels is so severe that it actually provokes a stroke. In these patients, besides avoiding triggers and using nonsteroidals, sumatriptan, zolmitriptan, and all the other 5-hydroxytryptamine agonists are extremely good at aborting the headache. Now, the most important thing for you to know about step 2 is that triptans are for aborting headaches, but when you have 3 headaches or more a month, propranolol or valproic acid are prophylaxis. Remember, triptans abort, beta blockers prophylax. Our final headache is episodic pain. It's unilateral. It feels like you're being stabbed in the eye with an ice pick. There's redness of the eye, lacrimation, and nasal stuffiness as that dripping eye starts to go down into your nose. Occasionally lid ptosis. This is a cluster headache, multiple short headaches in a short period of time. Great intensity. And the best initial therapy is sumatriptan, zolmitriptan. Oxygen is if those don't work, because oxygen needs to go to the emergency department. And we now have something new for you. There is prophylaxis with cluster headaches. You use verapamil, number 1, to prophylax those cluster headaches.
Pseudotumor cerebri is basically severe hypertension of your brain. It is associated with obesity and oral contraceptives and vitamin A toxicity. But the most important thing is it looks like you got a brain tumor. You got a bad, severe headache, nausea, vomiting, and you got papillary edema. Ding, 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 ding. That's the biggest. But the unique thing is that it's strongly associated with an abducens palsy. You can't look out. You can't look out. You can't look out to the side. Severe headache with papillary edema and abducens palsy. Now, some sources use the term benign intracranial hypertension. We do not use that term here because some people go blind. It was pointed out to me recently in conference that they did not consider blindness to be exactly too benign. So therefore, it is a pseudotumor. It looks like a tumor, but it's not there.
Okay, go ahead and look to your left. Now look to your right. Straight ahead. Look to your left. Look to your right.
Well, it's not bad now.
Straight ahead.
The diagnostic test of pseudotumor cerebri is certainly first the CT or the MRI. There is no calling it a pseudotumor until you've excluded the tumor. Person comes in with headache and papilledema, you better not be calling that pseudotumor until after you have the CT or the MRI and you know that it's normal. You've got to do this to exclude an intracranial mass. After you have a negative CT or MRI, then you do the lumbar puncture, which shows a markedly increased cerebrospinal fluid pressure. That's the diagnosis. Headache and papilledema with a normal scan of the brain, and then the LP shows a super high pressure. That CSF will be normal, not in terms of its pressure, but normal in terms of its content. In other words, no white cells in it. Normal CSF constituents, just a high pressure. The treatment of pseudotumor is to stop the oral contraceptives, lose weight, and if that doesn't work, if these benign things don't work, but stopping the cause or association like oral contraceptives, acetazolamide stops the production of cerebrospinal fluid. Acetazolamide, a carbonic anhydrase inhibitor, sometimes with furosemide, a loop diuretic, stops the production of the cerebrospinal fluid, and steroids can be useful. Now, in the short term, you got bad pseudotumor cerebri, bad intracranial hypertension. Don't be afraid to do a repeat lumbar puncture. Get rid of 10 or 15 cc's, and that pressure will go down. The person will certainly like you a lot. They're going to feel better. And VP shunt, or this is my favorite, fenestration of the optic nerve. Make slits in the optic nerve and help the cerebrospinal fluid to drain out your eye. And what happens is that the mechanisms for absorbing aqueous humor inside the eye actually absorbs cerebrospinal fluid. So the management of this is to stop the associated things such as weight loss or vitamin A or the contraceptives. If acetazolamide and steroids doesn't control it, you got to shunt it off and physically remove that extra fluid. Our next disorder is trigeminal neuralgia, sometimes called tic douloureux, the painful tic. It's exclusively a damage to the fifth cranial nerve, which is a sensory nerve, and gives severe, overwhelming knife-like pain. It's like being stabbed in the face with a knife. It's horrible. And it can be precipitated by chewing or touching the face or saying words that go top or trigeminal neuralgia. And somebody says, I've got trigeminal neuralgia, and the word with the T in it, the tongue hits the back of the teeth, and it's excruciating. They feel like they get stabbed in the face. And there is no specific diagnostic test that's generally done. We generally don't have to do nerve conduction velocities. It's a symptom complex. That's it. Carbamazepine is the best initial therapy and has been for decades. Oxcarbazepine is an alternative. Now, there are many medications for neuropathic pain. Baclofen sometimes works. Baclofen, which we use as an antispasmodic agent for people who have ALS, amyotrophic lateral sclerosis, or people who have multiple sclerosis, baclofen. Lamotrigine or pregabalin, gabapentin. There are a number of medications, of seizure medications that can be used for this. Because remember, all seizure medications have tremendous effects of neuropathic pain. Neuropathic pain means things like a peripheral neuropathy. Peripheral neuropathy is controlled by these medications, and they take some time to work. It's not like taking just a straight-on-ahead opiate or non-steroidal. It can take weeks to work. But when they don't work, we have to do surgical decompression. The best initial therapy is carbamazepine. If carbamazepine doesn't work, then you will try a variety of seizure medications. Valproic acid, phenytoin, lamotrigine, pregabalin, and ultimately, where the cranial nerve comes through the face, sometimes a blood vessel is squeezing it as it goes through. You have to surgically pull the vessel off the nerve, and it can be instantly curable. It's kind of a routine miracle. Postherpetic neuralgia is a great name. It means after herpes, particularly herpes zoster, you get pain after the herpes. Postherpetic neuralgia. It's a great name. And you get the vesicular lesions, and the dermatome gets inflamed, gets upset. We don't know why. We do know that it lies dormant in your neurons for the rest of your life. We know that immunocompromised people get a reactivation. And we know that by definition, older people above the age of 65, 70, 75, their lymphocytes just don't work as well. It's kind of like they're slowing down, kind of like my male pattern hair loss. It just doesn't work as much as it used to. And what you do is it's simply that you're treating with the medications to prevent the incidence of the neuralgia. Steroids simply do not work. People have been going back and forth in terms of steroids and the antiviral medications for a long time. All of these are equal. Acyclovir, valacyclovir, famciclovir, acyclovir, famciclovir, valacyclovir, all reduce the incidence of the pain. And the steroids, you want them to work, but at the end of the day, when they say, what do? You do not answer steroids. The treatment of postherpetic neuralgia, once the pain actually occurs, remember the acyclovir, famciclovir, valacyclovir is to prevent the neuralgia, to prevent the pain. Steroids are trying to do that. They don't work. But once you have the pain, tricyclic antidepressants, Elavil, also known as amitriptyline, gabapentin and pregabalin are in general the best of the medications for peripheral neuropathy, pregabalin and gabapentin. And as we have said, all seizure medications can work for neuropathic pain. Carbamazepine, phenytoin, valproic acid, oxcarbazepine. Topical capsaicin is different. That's alter substance P. That's alter substance P. We use it for osteoarthritis topically, and we could use it topically for postherpetic neuralgia. Now, when we're going to use the antileptic medications, I'm afraid that I cannot tell you which one is definitely better than another. That also means you can't be asked to choose between the different seizure medications. But do not confuse it if they give you a seizure medication and then mix it in with the other choices being things like opiates. You'll have to say, well, I will choose the seizure medication as the neuropathic pain med. Unfortunately, none of these ultimately work in more than 50 to 70% of patients. So you really have to do trial and error, and the problem is each one takes 2 to 6 weeks to improve, and therefore in the course of a year it could take you months and months to go through 4 or 5 drugs. Ooh, we got something new for you. It's fantastic. Everybody above the age of 60 should get a varicella-zoster vaccine. This vaccine is not to prevent you from getting chickenpox in the first place. This is to prevent the reactivation of that zoster. It's to prevent the reactivation and keep it in those neurons where it belongs. Don't come out. Do not get shingles. And of course, it's going to stop you from getting post-herpetic neuralgia because it's going to stop you from having herpes zoster. It's the high dose, quadruple the usual dose of the drug we give to prevent chickenpox in the first place. It's the vaccine we use for kids at high dose. So we get in there and give it to your father when he's 60 years old, and it works.